Hello, this is Kelly Curley, and welcome to Blood Transfusions. We're going to review the different types of blood products, some information about administering blood, and some transfusion reactions. As a reminder, students cannot give blood or blood products. We can assist with the setup, the monitoring, and actively watching the RN to assist them, but we cannot hang blood or blood products ourselves. So let's get started. First of all, type and cross match. Before a person can receive blood, they must be typed and the blood must be cross matched. Blood typing includes identifying the A, B, or O antigen, and also D antigens, which is our RH factor. The ABO typing identifies the antigen that is on the person's red blood cell membranes. The body then creates circulating antibodies to other blood types that are in our blood. So if you are type O blood, then you have O antigens on your red blood cell membranes, and we have circulating antibodies to type A, B, and AB. RH factor. There's a total of 5 RH antigens. However, the D antigen is most concerning. It looks to see if the client has the D antigen on their red blood cell. If they do, then there is an antibody that is created on that red blood cell membrane, and it can trigger an immune response. So once a client has had blood drawn that is to be typed, they will have a blood bracelet or a blood band placed on their arm. A lot of times it has red on it. It'll have their patient identifying information and a type annex number. There's an example of it at the bottom of your screen here. Do not cut this bracelet off. If you have to move this armband for some reason or another, you need to follow your facility policy. But this is not one of those armbands that if we need it moved for an IV or we need it moved because the patient would like it moved, this is not one that we can just cut off. We really need to be careful with that. Part of giving the correct type of blood and blood products starts with the fact that we have to be very diligent in our blood typing techniques and making sure that we have typed the right patient and we have their blood and that's the type that they have. The next part that occurs is the cross match. And cross match is when part of the donor blood is mixed with the sample of the recipient's blood. The blood bank does this and they check to see if it agglutinates or clumps together. They know that those blood products are not compatible. So they're looking to make sure that the donor blood and a sample of the recipient blood is not going to agglutinate or clump together. They would rather check this outside the body than to give it to the client and then, oops, something bad happened inside the client's body. ABO typing, just a reminder, who is your universal donor? Your universal donor is O negative. Your universal recipient is AB positive. Another reminder, your RH factor is inherited. RH positive blood can receive either RH positive or RH negative blood because the client has the RH antibody. However, if you are RH negative, you can only receive RH negative blood. If a client wants to donate blood for an upcoming surgical procedure, they may be able to do so. It's called an autologous transfusion. However, I need you to know that this is not a fast process. It usually takes weeks to donate, screen, have the blood ready, and it has to be a pre-planned event. Some clients will do autologous transfusions if they know they're going in for like an elective hip or an elective knee surgery and they believe that they could lose some blood. They may donate weeks in advance and then they'll have that ready in case. Autologous transfusions can also occur in the operating room. So you can get your own blood in the OR or immediately post-operative using specialized drains and blood tubing. An example of that is our SureTrans system. So if you'll see the drain in the bottom right-hand corner, it's a drain that can convert into an IV bag so that you can then receive your blood back. There are very tight restrictions on how often this can happen, how quickly it can happen after the OR. We wouldn't want blood that's been sitting in that drain for a long period of time to then be transfused back to your client. So there's a lot of policy that goes into that. You would want to make sure that you follow that, but clients can get their own. I've attached a hyperlink in your PowerPoint and also in the notes section. The hyperlink takes you to the American Red Cross, and it kind of talks about what happens to your blood after you donate. So what process does it go through? A lot of times people do want to donate blood for their family members. Unless it's a pre-planned surgical procedure, it's not going to be available for them for weeks. And by that point, they're typically out of the hospital. Whole blood. So let's talk about some different types of blood. So the first type of blood is whole blood. Whole blood we see utilized for acute massive blood loss. This is a trauma client. It may be military. It could be in a mass casualty disaster event. And whole blood contains everything that's in blood. So it's going to hold red blood cells. It's going to have plasma. It's going to have cryo. It's going to have platelets. It's got it all in there. It's not been spun and separated out into red blood cells and platelets and plasma. Nope, it's all together. So everything that's normally in your blood is in whole blood. Because it's typically used for acute massive blood loss, we're typically giving this as rapidly as the client can tolerate it. Does anybody know how fast an IV pump will set? Because blood is administered on an IV pump. It can be set at 9.99. So it can be ran as fast as the client can tolerate it. Yes, there are protocols for when the client comes in. If it's receiving blood or blood products and it is a trauma event, there are protocols for where you start the blood, how fast you can give it, and you would follow all of that if you were the nurse working in a trauma or an emergency room setting. You must have ABO identical for whole blood. We are going to monitor for signs of fluid volume deficit and signs of fluid volume excess. So if the client's having acute massive blood loss, they're going to have major signs of fluid volume deficit. That's why they're getting the blood. These clients are pale, hypotensive, tachycardic, low hemoglobin hematocrits. We see the blood loss being in front of our eyes. So we're monitoring those signs of fluid volume deficit. However, if we're able to get the bleeding stopped, we do need to make sure we monitor for signs of fluid volume excess in the long run. Are we giving them too many units too quickly? And are we going to send them into overload? At first, we just got to give it to them if they're losing it that much. But then we have to kind of start thinking after we've been giving it for a while, we probably need to reassess our client, right? Evaluate if those interventions are working. Are we sending them more towards excess? The next type of blood product is packed red blood cells. And this is what I see utilized the most often in our inpatient setting. So red blood cells are typically our most commonly given type of blood product, mostly made of hemoglobin, right? Because packed red blood cells have that heme molecule on them. We know the heme molecule on our hemoglobin helps to increase the oxygen carrying capacity of the blood. So we're going to see that if we give packed red blood cells, we're going to give more of those red blood cells. We're giving more hemoglobin. We're giving the body more ability to carry around oxygen within it. We see it utilized for symptomatic anemia. So the client is not just got to have a low red count or a low hemoglobin hematocrit, but they're symptomatic with it. It's bothering them in some way. They're having signs and symptoms of anemia. The anemia could come from the body not making enough red blood cells. So it could be an anemia that the body's not making it. It could come from blood loss, or it could come from the body breaking down too many red blood cells too quickly. Packed red blood cells have no functional platelets, white blood cells, or coagulation factors in it. It is just packed red blood cells. They've been spun down, separated out. This is just the red cells. A bag of packed red blood cells is about 300 mLs of total fluid volume. So if you're wondering, well, how much is in a bag? It's about 300 mLs. And 1 unit of packed red blood cells should increase the hematocrit 3 to 4% and the hemoglobin 1 gram. So we should see our hemoglobin come up by 1 gram. So if they were at 7.8, we should expect if they got 1 unit, they should be around 8.8. Platelets. So platelets are responsible for hemostasis, right? And what's a low platelet count called again? Thrombocytopenia, right? Low platelet count, thrombocytopenia. So we're going to see people get platelets because they need more platelets. They need help forming a clot. So we want them to clot. We want platelets to start sticking together, and they don't have enough platelets to stick together, right? We're going to see it used in the prevention of blood loss by stopping bleeding. And when we know that there are really low platelet counts. So to prevent blood loss by stopping bleeding, we've talked a little bit about red blood cells on the slide previously. If your client is actively bleeding and they have low platelets and they have low red blood cells, which one do we want to give first? Well, you're going to help your client more if you give the platelets first, because the platelets are going to help with the formation of a clot, right? They're going to help those platelets kind of stick together because you're giving them more platelets. So if we help the bleeding stop, we help a clot form, then that should help us when we give more red blood cells for those red blood cells to stay in the intravascular system. So if you have to give platelets and you have to give red blood cells, give the platelets first, then give your red blood cells, because we're going to try to get those platelets in there to stop the bleeding before we just give them more blood. If we just gave them more red blood cells and we didn't give them any platelets, they're going to continue to bleed. We're not stopping the bleeding. We're just filling up their tank and it's coming out the other side, right? Signs of low platelet count. So if you're looking at a client and their platelet count is low, any kind of platelet count that is less than around 50,000 and they're actively bleeding, they will usually get platelets. So less than 50,000, actively bleeding, we may see things like bruising, hematuria, petechiae, bleeding in their gums, blood in their stool. So at that point, they definitely need platelets. If they're not bleeding yet, but their platelet count is less than 20,000, they're probably going to go ahead and give them some platelets as a preventative measure. This is up to your healthcare provider. We see a lot of our hematologists working with these clients if they're at risk for low platelet counts. When they do platelets, they can extract platelets from multiple units of whole blood and pool it into one bag or from a single donor. So they can take, whenever people donate blood, and they can spin them down and they can say, okay, all of these platelets are AB positive. And so I'm going to pull these platelets and these platelets and these platelets and these platelets, and I'm going to stuff them all in one big bag, and they all go together. Or they can get it from a single donor. Fresh frozen plasma. So fresh frozen plasma, FFP, is the plasma part of the blood. Remember, half of your blood is blood cells, things like red blood cells, white blood cells, platelets, and the other half is made of plasma. FFP is the other half, right? It contains albumin, plasma proteins, clotting factors, and immunoglobulins. It works by, it's a volume expander is what they call it. It's going to pull fluid from the extracellular space into the vessels by this oncotic pressure gradient. So it's going to pull fluid from your interstitial area into the intravascular space. And it helps to replace clotting factors, which would help if your client was having trouble with clotting. Maybe they weren't clotting very well. It's used for severe bleeding, advanced liver disease, and complications from anticoagulants. It is frozen, just like the name says, fresh frozen. It's frozen. So it requires 30 to 40 minutes to thaw out in the blood bank. But it must be transfused within 24 hours of thawing out. So once they thaw it, it's got to be used within 24 hours. There are separate parts of FFP. Maybe the client doesn't need all of the FFP. Maybe they just need plasma protein, or maybe they just need clotting factors. So the healthcare provider can say, we just want to give them this part of FFP. They don't need all of it. They just need this little tiny piece. So let's separate these out and talk about the pieces of the puzzle. Albumin is a plasma protein. It pulls fluid from the interstitial space into the intravascular space by oncotic pressure gradient. It is given for low albumin levels and liver disease. Okay, so it's a plasma protein. It's going to pull that fluid from the interstitial into the intravascular space. Okay, and it does that by the oncotic pressure gradient. Cryoprecipitate. Cryoprecipitate contains clotting factors 8, 13, fibrinogen, von Willebrand factor, and fibronectin. So it's got clotting factors, and it's giving for clients that have clotting deficiencies, right? So it's giving for clients that have hemophilia, and maybe they're actively bleeding. Clients that have coagulation deficiencies, things like von Willebrand's disease. Clients that maybe are in a trauma that have a coagulation problem. Clients that are in this thing called disseminated intravascular coagulopathy. You don't need to know what DIC is at this point, but you will learn about it in your second level course. This client is very, very sick. So it's going to help to control that bleeding. Cryoprecipitate is frozen. It takes 40 minutes to thaw out, and it must be infused within 4 hours. The last part of FFP is a gammuglobulins. So gammuglobulins is the antibody part of our blood. One example of it is intravenous Ig or IV-IgG. So gammuglobulins or IV-IgG has mostly IgG in it, trace amounts of IgA and IgM. It's given for clients with antibody deficiency to prevent infection, because we know that antibodies help with infection, right? Help prevent infection, help our body to recognize that. So clients that are receiving gammuglobulins have a problem typically with their IgG level, and this is going to help protect them from infection. Alternates to blood transfusion. So if red blood cells are low, the healthcare provider can order medication that can be given. It's erythropoietin. Remember, erythropoietin is naturally a hormone that is made within the body in the kidneys to assist with red blood cell production. We see it given for chronic anemia, especially clients that have chronic renal failure or renal disease. If their kidneys aren't working, can they make this hormone? So this erythropoietin hormone is made in their kidneys. If their kidneys aren't working, they're not going to make the hormone that's not going to make the red blood cells. The other name for it is epitin alpha. It can be given subcutaneous or IV. Common side effects include bone pain, muscle pain, headache, paresthesia, diarrhea, and it can cause problems in clients that already have hypertension. If a client's white blood cell count is low, the healthcare provider can order some medications that are given for neutropenia. Remember, leukopenia is a low white blood cell count, but neutropenia is the low neutrophil count, which is that specific type of white blood cell. This client's priority problem is going to be infection and risk for infection. So there are two different medications that can be given. One is filgrastim or Neupogen. It can be given subcutaneous or IV. And the other one is pegfilgrastim, which is Neulasta, which can be given subcutaneous. The top two side effects of these medications are bone pain and headache. Let's talk a little bit about transfusion, the nurse's role before, during, and after. So before beginning a blood transfusion, we need to ensure that there's a blood consent form signed. The healthcare provider should have just discussed why the blood was needed, the risk and benefits, and any complications. We need to ensure the client has a patent IV site in. The book states a 24 gauge, and yes, in newborns, you can do that. But in adult setting and med surg, we really prefer a 22 gauge or larger. And even in our pediatric population, they're going to try to get a 22 or a larger line if they can. You have to have specific blood tubing that has an inline filter. You cannot use regular IV tubing. You have to use blood tubing, which has a specific inline filter. The tubing is primed with 0.9% normal saline. We need to ensure that we get vital signs prior to going down to get the blood. We need to know about vital signs prior, because if your client is febrile or having an alteration in those vital signs, we need to know that before we start the blood so that we can ensure that they're not having a reaction to the blood. We need to do some teaching, what signs and symptoms the transfusion should help with. That we will be monitoring vital signs frequently, that we will stay with the client at the start of the transfusion, symptoms to let the nurse know about. We will go and pick up the blood from the blood bank, and we'll do a check and double check with the blood bank. We're going to read back some information. They're going to read back some information to us, and we review all this information again at the bedside. So the blood bank check is really checking to make sure that we pick up the right bag of blood from the blood bank. During the transfusion, there's going to be a safety check at the bedside. So 2 RNs must check the order, the client bracelet, and when they're checking the client bracelet, they're identifying name and date of birth. They're checking blood type, RH factor, the donor number, the type and X number, the expiration date and time, the type of blood product that is being given, and if there is an ability to barcode scan, they're going to do that as well. The nurse is going to stay with the client for the first 15 minutes. That is typically our policy in the hospital, that we're going to stay with that client the first 15 minutes and monitor for a transfusion reaction. Once that 15 minutes is complete, they are going to make sure that we do vital signs. So we'll do vital signs before we start. We're doing vital signs when we start. We're doing vital signs 15 minutes after we start. And then we're going to be doing vital signs per policy. Some facilities want vital signs every hour, and then vital signs once the blood product is complete. If you go to get blood from the blood bank, that bag of blood product, once you take it from the blood bank, it has to be hung up and started to transfuse within 30 minutes of getting it from the blood bank. The entire bag of blood needs to be in the client in 4 hours. So the entire bag must be transfused into the client within 4 hours. There's usually around 300 mLs of blood in a bag. We always start the rate on the IV pump slowly, and then we increase that rate per policy to get the blood in within the 4-hour mark. Types of reactions. So here are some things that we would look for as far as reactions that our client was having a problem with their transfusion. The first one is a hemolytic transfusion reaction. And this could be acute or delayed. So hemolytic reactions occur because the client received incompatible blood. There's an ABO or an RH incompatibility. You gave the wrong blood to the wrong person. Acute occurs during, immediately after, or within 24 hours of the transfusion. Acute is really bad. These clients are very symptomatic. They don't do well. They can die. Delayed occurs days to weeks after the transfusion. The symptoms are milder. The treatment may be watch and wait. Sometimes delayed occurs if a client has received a lot of blood products over their lifetime, and maybe they don't have an antibody that we typically test for all the time. There are other antibodies out there that are not our routine testing, and they may experience a delayed reaction because they got the right type, but there's another type of antibody that is not as severe of a reaction, so they may have a delayed. Symptoms of acute, these are the ones we definitely need to watch for. Increased temperature, increased heart rate, chills, dyspnea, chest or back pain, bleeding, and decreased urine output. These are all bad signs that we should watch for. Nursing considerations. The big thing is prevention is key in this, right? This is why we always type and screen our clients at the bedside. If you're drawing blood and applying a type N X bracelet, you never leave the room during that process. If you have to leave the room, you have to start completely all over. The client is typed and screened at the bedside. You do not leave the room. It is why we check and double check with the lab, and we check and double check with another RN at the bedside to make sure that we're giving the right client the right type of blood. The next type of reaction is a febrile non-hemolytic reaction. It usually occurs with red blood cells or platelets, and what we see is a rise in temperature of 1 degree Celsius, which is about 1.8 degrees Fahrenheit, during or shortly after the transfusion. So for febrile non-hemolytic, this is why it's important we take those vitals before. Were they febrile before? Were they febrile after? Maybe their temp is going up. It doesn't mean that they're having this horrible reaction. It does mean that we probably need to contact the healthcare provider, and we may need to give an antipyretic or follow their instructions on what they would like for us to do. The next one is allergic or anaphylaxis. This occurs within 4 hours of transfusion. It is usually with plasma. Symptoms may range from mild itching to hives to wheezing, hypotension and tachycardia, nausea and vomiting, and they may have severe dyspnea and upper airway edema. Our treatment is going to be treatment for anaphylaxis if it is that severe. Things like antihistamines, epinephrine, supporting those vital signs. I don't expect you to know what treatment for anaphylaxis is at this time. You will get that content later on in your nursing program. The next type of reaction is TACO, transfusion-associated circulatory overload. This usually occurs within 6 hours. It is very deadly and it is common. So the risk factors for TACO include clients who are older than 70 or less than 3, clients who have a history of pulmonary edema, clients who have heart failure with a low ejection fraction, clients who have renal failure or are on daily diuretics, and that kind of goes back to the heart failure. Symptoms look like acute respiratory distress. These clients have immediate dyspnea. They're having increased rate, decreased SATs. They may have some frothy sputum coming up. They're going to have signs of fluid volume excess and signs of left-sided heart failure. We may do some diagnostic tests that would show an increased BNP or a chest x-ray that could show pulmonary edema. Prevention is key for this client. Clients that have a history of heart failure, renal disease, we want to transfuse that blood product at a slower rate. We have to get it in over 4 hours, yes, but that doesn't mean we have to slam it in 1 hour, correct? We can stretch it out over the 4-hour mark. Really, if you have a 300 ml bag of blood and you've got to give it over 4 hours, you can give it as slow as 75 mLs an hour and still get it in. So we don't need to see rates of 200, 250 on these clients because it could send them into TACO. So figuring out who's at risk, transfusion that blood product at a slower rate, ordering just 1 unit at a time. This might be the client, especially with heart failure, that gets 1 unit of Paxils and then they get some Lasix, some furosemide in between those 2 units of blood. And then they get another unit of blood if they need it. We want to assess and reassess these clients frequently. If your client is at risk for it, we need to be assessing respiratory rate, oxygen saturation, dyspnea, lung sounds very frequently. Treatment, if our client does go into acute respiratory distress, is to support them with oxygen and medications to help them through the respiratory distress. The last one is TRALI. TRALI stands for transfusion-related acute lung injury. This usually occurs within 6 hours of transfusion. It is typically due to the fact that white blood cells and inflammatory cells, things like cytokines and pro-inflammatory molecules, what it happens is it triggers an inflammatory response. When the body triggers that inflammatory response, granulocytes are activated and we get injury to the alveoli and capillary membrane. So where is your alveoli and your capillaries? Where do they meet up? In your lungs. So we get this acute lung injury because there's injury to the alveoli and capillary membrane. And what happens is that membrane becomes very permeable. So all of a sudden, stuff that's in your bloodstream is now getting inside your little alveoli where the air and CO2 should be. Probably not a good thing. Symptoms are acute onset of respiratory distress, increased respiratory rate, decreased oxygen saturation, pulmonary edema, and tachycardia. We're going to treat their signs of acute respiratory distress. We're going to give them oxygen, things to get fluid off, support their breathing. As far as the treatment for these reactions, we're going to talk a little bit more about it. If I don't mention the treatment specifically, you don't need to know specifics at this time. Trolley and taco are higher level. As far as treatment for pulmonary edema, we haven't talked about that in class. Same thing with anaphylaxis. We haven't talked about that in class. So just know that they're going to treat that symptom, that disorder that's going on, but you may not have all the parts of what that treatment looks like. So what are you going to do as the nurse if your client is experiencing a transfusion reaction? Well, if it is an acute hemolytic transfusion reaction, remember they got the wrong type of blood. If it is an allergic or anaphylactic reaction, if it is taco or trolley, we're going to stop the transfusion. We're going to change all of the tubing, take all the blood tubing down. We're going to change the IV tubing down to the hub, to the catheter hub. So we're going to hang up new tubing, new catheter tubing that goes hooked up to your IV. You want to flush all of the air out of all that tubing before you hook it to your client with normal saline. So you take all the blood stuff down, you're starting a new primary, new IV tubing, you're hanging it with normal saline, you're flushing all the air out, you're hooking it up to your client after you get the air flushed out of it. And you're going to infuse normal saline. You're going to notify the healthcare provider. Send the blood and the tubing back to the lab. There may be other nursing interventions. If it's allergic, anaphylactic, taco, or trolley, these clients may have breathing problems, and we may need to help them with oxygenation needs, right? For your clients that are having febrile, non-hemolytic transfusion reactions, they've spiked a temp. That's all that's changed. They're not having any other symptoms. Their temperature just went up. You're going to notify the healthcare provider, but you're probably just going to give an antipyretic and leave the fluids running or the blood running. Clients sometimes start to experience signs of fluid volume excess, but not necessarily taco. They're not in acute onset pulmonary edema. They're not having acute respiratory distress, but I'm starting to hear some more crackles. Their respiratory rates increased slightly. They may be still dyspneic and it's hard to tell if it's worse or not. For this client, making sure that you've done a thorough assessment before you start the blood, reassess afterwards and see, are we better, worse, the same? Notify your healthcare provider and slow down that transfusion. Your client may not be having a true taco reaction. Maybe they're just getting a little bit too much volume too quickly. Maybe we need to slow it down and give a diuretic, and your client may be just fine getting that blood or blood product. This is all I have for blood administration at this time. If you have any questions, please feel free to contact me. Thank you.